So, good morning. Thank you a lot for coming. This is going to be a fun grand rounds, I think. One of my really close partners, Ahmed El-Eshmawi, is going to speak. I'll tell you a little bit about him for those of you that don't know. Ahmed grew up in Alexandria, and he went to medical school, where, of course, like all you guys, he finished in the top 10 in his class, which I'm one of the reasons I love people that come from other places. Is the only way you get here is by being outstanding. So after doing that, he trained in cardiac surgery there and then went on to Germany to start, he was attending there, then went to Germany. I was doing surgery there, and then he came here to do a fellowship in 2010. His talk today is going to cover one of the most complex areas in mitral valve surgery, repair, or replacement, which is mitral annular calcification. So Ahmed, take the floor.
Thanks a lot, Dr. Adams. Starting, my talk is about as Dr. Adams addressed, a very serious and important topic in the arena of mitral surgery, mitral annular calcification. So as we getting used to present these grand rounds, starting with a question to address. So I would like to share that patient with everyone who was actually referred to Dr. Adams' service and to us for consideration of mitral surgery. This patient is an 80 years old female patient who has been known to have mitral valve prolapse for a long time, has been doing fine, reasonable quality of life, until one day she got admitted to a local ER with severe abdominal pain. She was found to have a rapid AFib. She spontaneously cardioverted and was transferred to Mount Sinai for consideration of surgery. We did again the full evaluation, including echoes, what we call a high-risk evaluation, because we know these cases are really very sick patients. It came up her heart cath numbers were non-impressive, low filling pressures, some non-occlusive disease in his peripheral vascular bed, and a few comorbidities, mild COPD, ex-smoking. This is a transesophageal echocardiogram. As you can see, there is a mitral annular calcification, very complex jet of MR. The angiogram, the LV angiogram, is very good ventricular function, normal size left ventricle, severe MR, extensive, as you can tell, the power of calcium. Huge left atrium, and her coronary angiogram showed 80% proximal right coronary lesion. So just to summarize, we had this patient who had been doing fine, 80 years old, severe MAC, known for years. She decompensated when she had an episode of rapid atrial fibrillation, and she had a coronary artery disease. The CAT scan, which is a very crucial part of evaluation of people with MAC, showed a very extensive mitral annular calcification as well as porcelain aorta. So the question comes, what should we do for this patient? Should we operate on the patient or just we should medically treat and follow up? Or should we do a staged procedure? Should we stent the right coronary? Some people recommended a clip, mitral clip, or something else. So the question for you guys, I mean, we only have 3 residents today. So we'll get back to that at the end of the talk. So mitral annular calcification, I have no disclosures. So as a surgeon, when I was assigned to do the MAC presentation, the first thing always comes to my mind is anatomy. We love anatomy, and this is one of the early editions of Gray's Anatomy. In 2 years, it will be 100 years old. As you can tell, they call the mitral valve as a bicuspid valve. And this valve is situated on the left side of the heart, surrounded by very crucial structures. Anteriorly, the aorta, the outflow tract, the circumflex laterally, and the coronary sinus toward the B3 region with the conduction system around the posterior commissure. However, as I started to do the literature search, I actually find 2 contradictory issues here. We, as a surgeon or in the surgical literature, saw MAC as a surgical challenge. So we always looked at the MAC from the technical standpoint. However, our fellow cardiologists or in the medical field, they saw MAC in a totally different aspect. They saw a MAC as a marker of advanced cardiovascular disease. And this is very important for us to understand too. So, and this is a paper that looked at the risk factors for MAC, and it's a cross-sectional study that involved over 6,000 patients. They looked at the risk factor, multi-ethnicity, atherosclerotic study, and as you can tell, if we take out the radiation and degenerative disease or rheumatic disease as a risk factor for MAC, almost every single risk factor is shared with atherosclerosis. So MAC can be in part associated with extensive atherosclerotic disease. But not only that, MAC doesn't only present the burden of atherosclerotic disease on the patient. Actually, MAC has been found to be an independent risk factor for cardiovascular mortality. And this is another important landmark article, is the Framingham Heart Study looking at the cardiovascular risk factors. And as you can tell, for age and sex adjusted cumulative risk, the cardiovascular mortality and all-cause mortality were higher in patients with MAC. And this was very impressive for me because they even found a linear relationship. For every 1 millimeter increase in the MAC, the cardiovascular mortality increased by 10%. So again, the purpose of my talk is not only to talk at the anatomy or surgical techniques about MAC, but we have, as surgeons, to realize the impact of MAC as a generalized cardiovascular disease. It is associated with diffuse coronary disease, stroke risk is higher, endocarditis, arrhythmias, particularly AV block and atrial fibrillation, and associated concomitant aortic valve disease. All this will impact your surgical outcome regardless of what we are going to do at the mitral valve level. And again, as I presented the case, after we look at the echo and the angiogram, we have to look at the extension of the vascular disease because that will definitely change the quality of life and the survival of the patient and will ultimately impact our decision who is operable and who is not operable. So I love history, so I looked back to see what was all this documentation of MAC in history. And this patient was found to be the oldest case of MAC. And as you can tell, there is extensive aortic calcification in MAC. And when I see all this, I really mean it because the patient was 3,000 years old. So this is a very famous study. It's called the Horus study. So they actually examined 52 Egyptian mummies. It was a shared study between Egypt and the States. And they did a head-to-toe exam for all these mummies, including multi-slice CT scan. 2 of these mummies have extensive mitral annular calcification, and lots of them have atherosclerosis. And what does this tell us? So there is definitely, we don't know exactly what are the cardiovascular risk associated with vascular calcification or atherosclerosis. Because the ancient Egyptians has been known to be actually very active. They were skinny, they hunted, they ate domesticated animals. There was no smoking at that time. And for sure there was no McDonald's or Burger King. So we don't know, are we really know all the risk factors for atherosclerosis, vascular calcification? The truth is we don't. And that actually explains some of the few cases. We still see patients coming with vascular disease or coronary atherosclerosis without any known conventional risk factors. And we wonder, is it genetic or is it a combination between genetics and environment? Getting back to our surgical concerns, MAC has been seen in the surgical literature. Actually, the interest in MAC started by recognizing patients dying after mitral valve replacement. That's when they first recognized that there are few patients after mitral surgery, they get left ventricular rupture. The first 2 case reports was 1967 by the clinical pathologist, Robert Amoro. So these clinical pathologists, they were very interested to examine autopsies from all patients who die after mitral valve surgery, because mitral valve replacement was started to be the standard of care for valvular heart disease. They collected almost over 600 autopsies from centers all around the countries, and they examined them in Maryland, very detailed description of the autopsies. And they basically told us everything that we know now about the complication of valvular heart disease. Valvular heart disease replacement with. So they collected patients with mitral or aortic valve replacement or combined replacement. And they described outflow obstruction by a bulky porcine prosthesis. They described the circumflex occlusion from a suture used to ligate the left atrial appendage. And I know Dr. Adams have a special interest about that lesion. We always debate who we should close the appendage and who's not. They described aortic dissection after aortic valve replacement above the aortotomy. And they also described cases with left ventricular rupture after decalcification of the mitral valve. And as the interest goes on with left ventricular tear or left ventricular rupture, Donald Miller actually described that. 1979. We are not familiar about LV groove disruption classification, but this is a very accepted and respected classification. We pay more attention to the AV groove dissociation, which is type 1, and that's because this is a more common type. It happens if you have a destroyed annulus, either by endocarditis or by surgical decalcification of the mitral annulus. Type 2 is less common recently because historically, surgeons used to pull too much on the posterior babillary muscle and amputate actually the muscle doing mitral valve replacement, and then created a dissection hematoma and more apical form of AV groove disruption. The third type is the most elusive and perplexing type. It's called the mid-ventricular tear. It's not close to the apex or the annulus. No one knows exactly what is the mechanism, and of course we don't know how to prevent it. So as you keep doing mitral valve replacement, particularly, that injury can happen, particularly if you do non-valve sparing valve replacement. So how to handle calcified annulus? The honest answer is we don't know. We don't know exactly what to do. There is no simple reproducible technical resolution for MAC. All what we have is many techniques and no general consensus for that. However, just to simplify a complicated topic, there is two schools of thought, either resect or respect. Resect has been historically seen as a standard of care, which means annular decalcification and annular reconstruction, and we'll talk about that in details. Respect means working around the calcium, so no need for annular reconstruction. And there are too many techniques. At Mount Sinai, we pioneered the oversized annuloplasty and unconventional annuloplasty as a way to handle MAC in degenerative patients. And finally, I will talk about alternative approaches, including the use of hybrid devices in MAC, if non-conventional or conventional surgery cannot be done. So again, it's a scale. The two ends of the extreme. Nothing is perfect when it comes to MAC. If you resect the calcium, you definitely provide a smooth and pliable living tissue for the prosthesis to heal. However, that will definitely increase the risk by definition of AV groove rupture. If we respect the calcium and we work around the calcium, we would probably avoid the AV groove disruption. But on the other hand, we have the other enemy, which is paravalvular leak, which is not a benign thing to happen at the mitral position, as we will explain further. Starting by resection, I'm going to show a patient who actually had a previous mitral valve repair with mitral ring implanted on top of the calcium part, and as you can tell, he had a recurrent severe mitral regurgitation. So this was the intraoperative video. As you can tell, there is a severe mitral regurgitation, central alveolar stage, which probably was compensating for the residual leak. We always do this re-repair starting by excising the annulus, and now we can tell that there is a calcium pore extending behind the annulus deep into the left ventricle. We started by disinserting the posterior leaflet, and as you can tell, this is a very sharp dissection within the fibrous capsule of the annulus, and we can see the AV groove visible behind the calcium pore. Usually it is commissured to commissured decalcification if you want to do debridement, and we reconstructed the annulus using the sliding ventriculoplasty, atrioventriculoplasty technique, and we close it with what they call the figure of 8 matrix suture. We have to be very gentle tying these sutures, and then we use a second layer of pledgeted sutures for the implantation of the prosthesis. Of course, you can do mitral valve replacement or a repair. This is a different discussion. We reconstructed the posterior leaflet with a pericardial patch. Promising sealant testing. The final result was good coaptation zone, no mitral regurg. So just to shed some light on the sliding atrioventriculoplasty. These techniques have been pioneered by Dr. Alain Carpentier. The beauty of that technique, apart from the patch augmentation, it provides a viable living tissue covering the annulus, and that's what he explained, that this is the reason why he had a good long-term result. The other advantage of that procedure is it everts the AV groove when you advance the atrial flap down to the ventricle, and in that way that will decrease the risk of circumflex injury, and he never had one in his series. So this is a landmark paper. Dr. Alain Carpentier published 68 patients with extensive MAC, decalcified. His hospital mortality was only 2.9%. He never saw AV groove disruption or circumflex injuries with good long-term results. So it looks like every patient who survived that surgery, they did well in terms of their survival and quality of life. However, just looking at the diagrams, it's a huge paper. He illustrated carefully all the extent of the MAC in every patient. I can tell that most of the patients, they had only 1/3 of the annulus affected. And the more circumferential type of MAC, which we actually recently see more frequently, was about 1.5% of the cases. So he commented on his paper when it was presented in the AATS meeting at Boston 1995. He said, I think the long-term result is probably better if you can do complete resection. I've never seen any injury of the circ or distortion, probably because of the sliding blasty. However, he added, he said, of course, it took me some time to develop and to have the courage to do that operation. So if the master of that field who started to say, I need to have some courage, I'll be a little bit skeptical in offering it to everyone and to myself. And fortunately, Dr. Tyrone David was in the same meeting and he commented on his paper. And he said, instead of mobilizing the left atrium, he took a strip of pericardium and did pericardial patch from commissure to commissure. And the reason for that, because he was honest, he said he had an AV groove disruption with a sliding blasty. So it can happen still. I mean, it didn't happen in Dr. Carpentier's serious, but other surgeons encountered that. And that takes us to the next surgical modality to reconstruct the annulus, which is a patch reconstruction of the annulus. Tyrone David adopted that technique and he used an autologous pericardium to reconstruct the annulus. Again, he published his own series, 54 patients. Operative mortality 5 patients, which is about 9.5%. So still, whenever you decalcify the annulus, we have to accept that risk, which is, it can vary from maybe 9-10%, even more in some other series. But it goes up to the same thing. Patients who survive, they do fine because we basically take out the calcified annulus and provide a living tissue to heal the prothesis. So I did the math between the two masters, and Dr. Carpentier did 68 and Tyrone David did 54. So the total published from both of them was 122 cases. Again, still I'm skeptical and advocated that the procedure as the standard of care. So just for purpose of completion, there is actually a forgotten technique to reconstruct the annulus. It's called the anterior leaflet flip. Castleman, they did that, they innovated that technique. They did 20 cases, they didn't find even one single AV groove disruption. And it is a very attractive approach in my point of view, because you take if you have a pliable anterior leaflet and you flip it back and you reconstruct the annulus with that leaflet. And the advantage of that leaflet, which neither sliding blasty or patch augmentation provide, is, as you can tell, it restores the ventricular atrial continuity, which will protect you from having AV groove disruption, because we are already susceptible for it by definition after we do the decalcification. Again, it's not famous or didn't attract much attention, I think, because of the, it's unusual to find severe MAC with almost a big normal anterior leaflet that we can reconstruct the posterior annulus to. However, the reason I'm bringing all this historical literature, because you never know, in cardiac surgery, you can use one of these historical techniques actually in any patient, because every patient is different. And as we moved to the, what are the contemporary literature? If there is any recent literature about en-bloc decalcification, I found few. So Dr. Al-Khoury published from Bruxelles 24 patients. Look at his surgical mortality, almost 12.5%. So he was very honest in presenting that result. And he said it's clear, however, that decalcification increased both the complexity and risk. Another series from Frankfurt, 109 patients. Almost a very close result. I mean, the surgical mortality was 8.3%, with good long-term result for the patients who survived. So what about reality? We presented the literature now. Actually, in reality, the way I see it, it takes only one long day trying to repair an AV groove disruption of isolated mitral valve operation to consider less radical approaches to handle the MAC. Because we are humans. Surgeons are not superhumans. So if you presented with a patient with extensive MAC, advanced age, friable tissues, and we know that the surgical mortality will be maybe 15, maybe 20%, what should we do? So it's like surviving a catastrophe. You can have a post-traumatic stress disorder from that. So, Nicolas Medera is a surgeon from Cleveland. He actually mentioned that in one of his surgical techniques describing how to handle MAC. So he had this informal survey for surgeons at Cleveland Foundation. And interesting because he found that he didn't find a single surgeon who will do en-bloc decalcification. And everyone would say they will never remove any calcium or only take minimal calcium enough to implant a prosthesis. And this was surprising and in contrast to the written literature. However, as a matter of fact, practically that's what we're talking about every day. So how to handle a MAC with a respect strategy? So as you can tell, now we are evolving. So respect was born as an offspring from the resection because no one wants to have an AV groove disruption on the table. I'm going to present for you patients. So the first concept that we adopted is oversized annuloplasty. We see a lot of degenerative patients. Many of them, it's a risk factor as I addressed for MAC. This is a patient who had a bar of calcium, as you can tell, extending almost a centimeter behind into the left atrium, deep into the ventricle. Excess tissues, Barlow's case. The standard of care for us to do a resection technique for this kind of patients. So we did the sliding blasty, but at the leaflet level in front of the MAC, and we reconstructed the posterior leaflet. We put the annular sutures behind the MAC. And you have to be careful when it comes to B1, P2 area because the circumference can be as close as 1 millimeter. And as you can see, we use sometimes different techniques, everted sutures with bled jet from the ventricle deep into the atrium, almost bouncing behind the calcium pore to avoid ligating the circumflex. The final result, the sealant test. Next comes sizing. By definition, you have to oversize. Here, not only because of the Barlow's and the excess tissues, but also because we have a calcium pore that we will implant the prosthesis in front. So we have an excellent result, very deep coaptation, no SAM, no mitral regurg. The other concept or theory is what's called the Unconventional Annuloplasty. And what does this mean? It means to adjust or adapt your annuloplasty techniques depends on the burden of the mitral annular calcification. So this is a case, anterior leaflet prolapse, fibroelastic deficiency, severe MR, calcified anterior leaflet and hinge point. Intraoperatively, you can see the body of the anterior leaflet at A2, A3 is calcified, the aortomitral calcium is calcified. Posterior bar of calcium, severe mitral regurg, and anterior leaflet prolapse, cleft in the posterior leaf, very complicated valve. So as we start always by exposing the valve through annuloplasty suture. So if you can see, we spare the annuloplasty suture toward the anterior commissure. We added a Gore-Tex suture as a way to handle the anterior leaflet prolapse. The final sealing test, and then the unconventional annuloplasty. So in this particular case, we found that the anatomy is favorable for using a triad band and leave the open end toward the anterior commissure, toward the AV, the left ventricular outflow tract and the anterior commissure, and we have a good echocardiographic result. So what are other techniques? The leaflet extension, I'm going to just rapidly go through every one of these techniques because, again, it can be still important in the current armamentarium. So the leaflet extension has been started not for MAC, but this technique has been adopted for managing patients with either rheumatic repair, as Dr. Carpentier presented his long-term result, or for tricuspid valve repair, as Robert Dion from Broxel presented these cases. So the same concept can be applied for mitral annular calcification. So this is a patient who had a Parlow's case with calcified anterior leaflet and anterior MAC. The intraoperative video, the whole body of the anterior leaflet was calcified, as well as the anterior annulus. So we started by disinserting the anterior leaflet and excising the bulk of calcium from the body of the leaflet. We use multiple belegitated sutures which we will use to reconstruct the anterior leaflet, and we use a batch reconstruction using a CardioSeal batch. Final result, good coaptation, no mitral regurg. What about the bi-orifice repair, Alfieri repair? Again, I wouldn't abandon that procedure in mitral annular calcification, but if it's used, it has to be an adjunctive technique, not as a primary surgical strategy. I'm going to present a patient with Parlow's disease and severe MAC. the intraoperative video. As you can see, there is a posterior bar of calcium that was actually clearly extending deep into the ventricular myocardium behind the B2 segment. So after we did the annuloplasty and the non-resection technique, we added a central alveoli stitch. We used actually a couple of Prolene sutures, and we didn't have any MR at the end. So what about just using an alveoli stitch if you cannot put an annular sutures? Don't do it, because the midterm result by Alfieri himself, he abandoned that technique for MAC. So the result for MAC for solo Alfieri was terrible. Patients, almost all the patients came back for surgery. So he said he considered the mitral annular calcification as a contraindication, and this is very important because still some intervention cardiologists would recommend mitral clip for a patient with MAC if the leaflets are not calcified, and that doesn't go with our surgical literature. So what about mitral valve replacement? Historically, before the mitral valve repair, the surgeons used to do valve replacement, and it is very challenging because they have to do this atrial implantation of the prosthesis. This technique has been largely abandoned because it exposes the left atrial friable tissue to the very high ventricular pressure, and there is a huge amount of bleeding in these patients because of the tearing of the atrial tissue. So it has been pretty much abandoned. But what about mitral valve replacement at a supra-annular position? I will present another case that we did here. Another patient who came a few months ago. She had severe MAC, severe mitral regurg, mild aortic stenosis. I have a very quick video. As you can tell, this patient had severe MAC, circumferential, but you see, as we try to explore that valve. This is not an ossified valve, because sometimes you see like an ossification of the valve. This is more like fibrosis combined with calcification. So you can drive needles through that valve. I don't have the picture for the valve, but I had the echo. Patient had a mitral valve replacement on top of the calcium part, and she didn't have a drop of paravalvular leak, which was impressive after we finished the case. What about intra-leaflet implantation or intra-annular implantation? This technique has been pioneered by Coselli, and the reason for him to think about implanting the prosthesis at annular level, because that procedure will avoid transmitting the ventricular pressure to the left atrium, so it compensates for the bleeding issue. However, there are two risk factors associated with that technique. First, you have to implant a small prosthesis. Second, it is associated with paravalvular leak. So this is another patient. Again, we saw that patient. He was a renal failure patient transferred from PES Israel to us for consideration of mitral valve surgery. When we explored that valve, we found actually the extensive posterior MAC, and the leaflets were pliable. So we implanted the valve leaflets, the valve suture at the leaflet level. And as we tied them down, you can tell that the patient already, we started to see we just talked about the paravalvular leak, inevitable in these patients. So you have very limited options to do. We buttressed basically the atrial wall to the cuff of the valve. We came off bypass, there was mild paravalvular leak, which was acceptable at that time. However, I still consider it as an inferior result, but this was the other alternative to avoid AV groove disruption. And combined techniques, surgeon combined all these techniques, so they said, fine, we will suture a donut to the cuff. We suture the cuff to the annulus at the leaflet level, and we suture the donut on the left atrium, the pericardial extension, so that we can compensate for the paravalvular leak. De Stefano from Spain, he recommended what he called the generating a new annulus, so he plicated the leaflet to the left atrial tissue, and that created a new annulus. I think these techniques would probably be feasible in endocarditis cases, or if you have a destroyed annulus, but can be also used for mitral annular calcification. So what about the extracardiac shunt? So this is an interesting approach. Why about just to bypass a mitral valve? And this is primarily indicated for circumferential MAC with severe mitral stenosis. So it was fortunate that the first author on that case report, Sameh Said, he was my chief resident when he was in Alexandria. So by somehow he went to Cleveland Clinic, and he's a congenital surgeon, and I found that he's interested also in mitral annular calcification. So we know that the concept of shunts is known in cardiac surgery, particularly in pediatric. We do RV to PA shunts in pulmonary atresia. We do apico-aortic conduit for severe LVOT obstruction. So why not to consider the concept of bypassing the mitral valve and putting a tube graft with a valve from the left atrium to the apex? He published a case report. My communication with him last week, they did 11 cases. They had 2 mortalities. Both of them was multi-organ failure. The other patients did fine. So this is the intraoperative pictures for this surgery. The last technique I'm going to advertise is the hybrid devices. So what about if we cannot do any of these? We cannot resect, we cannot respect the calcium, and we have to do something. I mean, if there is an option to close the chest, and the worst thing can happen, but what about hybrid devices? We advocated the concept of extensive MAC, which is not amenable for standard surgery, to use a balloon expandable devices, whether a Sabian or a Melody valve. So basically, we use the calcium as a landing zone, just exactly like the concept in a TAVR. I'm going to present quick 3 cases. The first case, 75 years old, heart failure symptoms, severe MAC, severe mitral regurg. We explore that valve. You can tell from the CAT scan, a huge amount of MAC, circumferential, extending deep into the ventricle. Again, this is the 1% I showed in Dr. Carpentier series. The Melody valve is a stented bovine jugular vein, which is, as we know, designed for percutaneous use in the mitral position. We mounted this valve on a balloon catheter, and under direct vision, we implanted it in the mitral annulus. First, we start by sizing the mitral annulus using the angioplasty cath. It has to be snugging through the annulus. And then we introduce the valve under direct vision. You don't need fluoroscopy or any other guidance. It has to be very gentle because it can create an LV perforation, which we encountered in few patients. The valve is deployed, and as you see, it stented open that mitral valve. Very important, because the purpose of this surgery was not to cure mitral regurg, was to cure severe mitral stenosis. Patient had normal left ventricle, she had some MR, but her main issue is severe pulmonary hypertension and severe mitral stenosis. The forceps manipulation test is important because these valves are prone to embolization. As we will clarify later, the valve seated well, good function, trivial central jet, which is inevitable because these valves are bovine jugular veins. They are not designed to sustain a systemic pressure. 18 months follow-up was very favorable. Some outflow obstruction started in the 40s. On follow-up, actually, the outflow gradient was 16. And there is no significant valvular or paravalvular. And what I think happened in that patient, as you can see, there is some thickening of the leaflets. It could be that these valves, when it gets exposed to systemic pressure, they get some sort of remodeling. We published that case in the annals. She did great. She's still alive 2 years after her surgery. And we had a great success with that patient. That pushed us to be more enthusiastic, to do more cases. And that's actually when we started to see complications of that procedure. So 90 years old, the second case, multiple admissions in heart failure. Everyone was begging us to operate on the patient. Patient had severe MAC, LV dysfunction, and severe mitral regurg. You can tell from the CAT scan, this is a massive amount of mitral annular calcification in addition to the porcelain aorta. Again, getting back to the same concept of MAC and atherosclerotic disease. We did it under fibrillatory arrest. The problem with this case, because she lacked the anterior landing zone, because it wasn't a circumferential MAC. So we had to implant a band so that it works as an anterior landing zone. And then we deployed the prosthesis in place. Forceps test was very assuring. It was very quick case to do. We came off a bypass. Sure, thanks. We were happy, and finally, immediately, almost once we restored the circulation, the valve got embolized into the left atrium. Again, one of the inherent problems with balloon expandable devices in the mitral position, because it's exposed to the very high ventricular pressure. So we went back, we took out the valve, and then now what to do? We actually tried to create mitral stenosis, because again, if these valves are considered, they should be considered primary for mitral stenosis patients. We closed the commissure with pledged suture, we implanted the prosthesis again, but we're not gonna take our chance today. We will actually suture the valve in place. So we added some Prolene sutures to provide further anchoring for the device in the mitral position. We thought we are done, we are fine, and the problem of embolization has been taken care of. But then we do the sealant test, and you have this 6, almost 7 o'clock gap at the annulus. So there is a huge paravalvular leak at that place. The only thing to do at that point, we do these cases with Barry Love. We asked him to get an Ambletzer devices, and we deployed it under direct vision, and we didn't have any single drop of paravalvular leak in that patient. The third case, again, another complex case, patient had 2 sternotomies for bypass and then aortic valve replacement. She came with MAC, severe mitral regurg. And when I read the same surgeon did the first 2 surgeries, and he was a very detailed surgeon in his description. So I was looking to see what did he see on the mitral valve when he did the aortic valve replacement. And he exactly said there was a severe amount of MAC, moderate mitral regurg, but he left it alone because there was nothing to do at that time. So he preferred to do only aortic valve replacement, and I think this was a good decision at that moment. Now the patient came back. So we explored that case. As you can tell, there is severe amount of MAC on the CAT scan. We moved toward doing these cases on fibrillatory arrest because we thought, not only because of the porcelain aorta and decreasing the risk of cross-clamp, but also having the tone in the muscle that probably will provide us with more protection from perforating the left ventricle as we manipulate the valve. It's one of these ossified valves again, so we close the indentations in the posterior leaflet, and the reason for that is to protect us from the paravalvular leak, which we will expect to happen now after we did the second case, and on the other hand, to provide some sutures that we can place in these bledges so we can provide further anchoring so we don't get the embolization. We did deploy the leaflet, the valve, and again, because of the non-uniform landing zone for these valves, severe paravalvular leak at the 2 o'clock position. But now we know what to do for these cases. So we asked Barry Love again to get us the Ambletzer device. And as you can tell, there is some vertical instability of that valve. And on the other hand, we have been more atrial than ventricular because we were worried about inducing an LVOT obstruction. We sutured the valve in place. And this is the final sealant test. Always you have this central jet, but this is inevitable again in patient with normal ventricle that should be well tolerated. And we took care of the paravalvular leak using the Ambletzer device because you cannot put sutures there. We had a good result, mild LVOT obstruction, no MR, no paravalvular leak. And this is a 3D reconstruction for that valve and the device. So just going through the challenges of hybrid devices, I just picked up 3 issues which we personally encountered in our series: paravalvular leak, outflow obstruction, and coronary compromise. Paravalvular leak is never a benign condition in the mitral position. And this is, I found that article is actually a nice article because there are very few literature about natural history in cardiac surgery. So these are 52 patients, half AVR, half MVR, and they have mild to moderate paravalvular leak, not needing surgery. So they excluded patients with severe paravalvular leak or endocarditis. They just followed patients who needed follow-up for mild to moderate paravalvular leak for over 3 years, the median follow-up time. And look what they found. The event-free survival for paravalvular leak after mitral valve replacement was about 16%, as for the aortic was 77%. So definitely the paravalvular leak can be well tolerated in the aortic position, but not on the mitral position. And even spontaneous resolution of the hemolytic anemia didn't happen much on the mitral position versus the aortic position. So what should we do to avoid the paravalvular leak? We should liberally oversize these valves to compensate for the paravalvular leak. Again, device plugging I have mentioned. It will be very challenging to do that in the cath lab when we start the transcatheter trials. I guess the option will be a percutaneous closure. However, I looked again, I found a paper from Al-Khoury, and he described, if you remember the donut extension I showed you for the combined procedure, he did exactly the same. He employed a Sapien valve, and to compensate for the paravalvular leak, he sutured the pericardial patch extension to the left atrium in a patient with extensive MAC. What about the perioperative ischemia? Perioperative ischemia, every time you do a mitral valve replacement, particularly in patient with MAC, you have to be careful about the circumflex because that's what you don't want to end with. A giant circumflex coronary artery, left dominant system, and got occluded by a mitral prosthesis. We stented that patient. She did fine. She was a 3rd-time redo case. But the point is, as we do mitral patients and patients with MAC, few of them will get coronary injury, and we will be lucky if it's non-dominant circ. Some surgeons advocated even throwing a vein graft on that circumflex because if you are already in troubles in the OR, and you know now we have a mitral prosthesis and the OM is occluded, you cannot invert the valve because now you're technically asking for AV groove disruption to happen. So what about the LVOT obstruction? I will show a case that I did with Dr. Falsufi. He is a patient who had a severe MAC, severe MR. We thought that the patient was a good candidate for a balloon expandable device. We implanted the valve, but we did a mistake in that patient. The mitral valve was too ventricular. It should be 2/3 atrial than ventricular. And look what happened coming off a BES. The outflow was totally occluded. Of course, the patient did not tolerate that lesion, particularly if he was already prone for that because his outflow was 1.6 centimeter. Ideally, it should be above 2 centimeters. So how to handle the LVOT obstruction? First, exclude patients with high risk, including septal hypertrophy or mid-ventricular or outflow gradient. Atrial positioning, then ventricular. Use a low-profile valve like a Sabian valve. Septal myectomy, it just came to my mind because of Dr. Stelzer. One case we discussed with him, Big Mac and septal hypertrophy. I think you did one case yesterday with Dr. Adams. And but also I found that interesting concept. Rakesh Suri from Mayo Clinic published that case. He deployed a CBM valve, and to avoid, because he was very worried that the anterior leaflet will go in the outflow and kink the outflow tract. So he cut the anterior leaflet, and the valve was landed well. If you want to summarize everything together, I would advocate everyone to read that commentary by Dr. Adams and Dr. Annie. They summarize all the technical challenges of transcatheter mitral valve. This is not a TAVR. And is it going to be a game changer in the future? Probably, but this is going to be a very long time because, as you can tell, we already have too many surgical issues with the open patient. So imagine how can you handle that in the cath lab. So basically the mitral valve is a very complex annulus. It's not a circular annulus, it's a saddle-shaped dynamic annulus. There is a very poor tolerance to paravalvular leak in that position. You have to be careful not only about the coronaries but also the outflow tract. And conventional surgery always can offer you maze or tricuspid management in patients with severe mitral annular calcification. So there is anatomical risk, there are technical risk, because as we know, the aortic valve is basically on the highway of the heart. You can go through the aorta and get to the aortic valve. The mitral valve is not. It is a left-sided valve. There is a lot of steering involved in reaching out to the valve. So it can be transapical, transseptal, transfemoral. So I have put this selection criteria, what I would personally imagine what should be the indication of transcatheter device in the mitral position. It has to be a circumferential MAC or posterior MAC with an in situ aortic valve, because that will work as a landing zone. Severe mitral stenosis should be ideal, or MS with MR. Isolated MR, big giant annulus, that's not is going to be challenging, and we were still waiting for the ideal prosthesis for that. No septal barge or outflow gradient. Sabian over Melody, because as we know, Sabian is a pericardial valve, more prone to tolerate high ventricular pressure, and it's a low profile valve, so it protects you theoretically against outflow obstruction. And we will be entitled to start a clinical trial in using the transcatheter CBM valve in the mitral position in the next few months, and I will be the PI for the center, and Michael Mack is a PI of the clinical trial. So finally, again, just getting back to the question, so what do you think we should do for that patient? 80 years old, just reminding you again, good quality of life, severe MR, some coronary disease, living alone, driving, shopping, low filling pressures, and porcelain aorta. What are you going to do for that patient?
I think I stick to my original answer, is that if I'm in a center of excellence where they can fix this problem, then probably.
What do you think?
Maybe stage procedure, I think.
We said MitraClip is not a good option for her. She needs something done to the mitral cell, go with surgery. Again,
so why do you think that she needs something done? Just because of her echo or cath?
Symptomatic.
She had
She's class 2 symptoms. Only got admitted once to the hospital in rapid heart failure and in rapid AFib, and once she's in sinus, she's fine. What is the risk-benefit ratio? I mean, I'm not saying right or wrong here. You can do anything, but what's the best risk-benefit ratio for the patient? What should we tell the patient? What she's going to gain by doing a high-risk procedure for her? Is it survival benefit or a quality of life issue?
wouldn't it be? I mean, she just have to have something done for the right, but for in terms of the regurgitation, quality of life. Although, like you said, it's class 2, so.
So I'll leave Dr. Adams' comment on that. Finally, just, originally I came from Egypt, so everything is about history. Just to take our brain out of this complex issue. This is, does anyone knows what this is?
Rosetta Stone?
Rosetta.
Yes, excellent. So Rosetta Stone is a trilingual stone that was found in Rosetta, which is a very little city close to Alexandria. One of the soldiers of Napoleon, 1799, when they came to Egypt, he found it. And they know this is a precious piece because it has 3 languages. So basically, the script was written on the top portion by the hieroglyphic Egyptian language at that time, which was a language used by the priest for religious correspondence. The second transcript was what they call the demotic language, which is a language used by the lay people in Egypt at that time. And the poem was script was the Greek, the ancient Greek language. So basically, that was the key to decode the hieroglyphic language at that time. It took 100 years to happen. And the one who did it was also French, Champollion. And when the British came to Egypt at that time, they took over from the French, so they took the stone actually to the British Museum. And until now, it's the most visited piece in the museum since 1802. Thank you very much.